Hi, welcome to Learning Plan 5 Part G, Blood Clotting. Blood clotting is a major importance from so many reasons. It can be very good or very bad, depending upon why and when it's happening. There's three types of medications that affect blood clotting: antiplatelet or platelet inhibitors, thrombolytics, and anticoagulants. These are very different medications used for similar purposes, but with very different effects. So let's talk about each one individually. The clotting cascade is many different steps that happen in a specific and precise order. And if one isn't able to happen, the rest stop. So that's the clotting cascade. And the reason why there are so many different medications is each medication affects a specific part of that cascade. The beauty is you can use a little bit of medication to affect different parts of that cascade and reduce the overall side effects because you're using small amounts. Remember, the additive effect is a good thing. It allows you to use less medication to reduce the risk of any one drug causing side effects. Clotting cascade is caused by proteins that normally circulate through the blood completely inactive. They're just in the blood. They have to be activated to form a fibrin clot. And the activation, the trigger, is either increased blood viscosity, blood thickness, or damage to a blood vessel wall. Now, the blood thickness or the increase in viscosity usually happens when a person is immobile for long periods of time. So it could be from surgery. It could be illness. It could be a person on an airplane flying for 8 or 10 hours and sitting in one spot with their legs, in a sitting position, so their ankles are very dependent and reduced blood flow. But for whatever the reason, when you have very reduced blood flow, that blood sits, it pools, and it can start forming a clot. That's really bad. It forms in the veins of the legs, and we call these a deep vein thrombosis, or DVT. DVTs in and of themselves are bad. They cause pain and discomfort, but the real risk is parts or all of that DVT could break free, and it'll float along the path of that vein, back up the inferior vena cava, into the right atrium, into the right ventricle, and then get blasted up into the lungs where they form a pulmonary embolism. Pulmonary embolisms cause great amounts of pain, difficulty breathing, and death. So, we want to prevent that clot from forming. Injuries to the blood vessels could also start a clot formation from surgery, from trauma, car accident, things of that nature. Anything that causes that damage to that inside of that blood vessel will trigger a clot formation. It can also happen when plaque buildup is in the artery, and that the fibrin sheath that covers it becomes exposed, causing more clotting to happen. So that's what triggers the beginning of the clotting cascade. So if the blood vessel wall is injured, collagen is exposed, collagen in the vessel wall is exposed, and platelets start going there and sticking. And as they stick, they start to release ADP, and that forms a platelet plug. That's important to prevent bleeding, but if it forms on the inside of the vessel, then it forms a clot and a plug, and that is where it gets very bad. There are two types of pathways. There's intrinsic and extrinsic pathways. Intrinsic pathways are triggered which stimulates the conversion of prothrombin to thrombin. And intrinsic is something within the blood vessel itself. Extrinsic is external to the pathways, and it also causes the formation of thrombin. Always remember, intrinsic within whatever you're talking about. Extrinsic is something from the outside applying pressure. Each activated factor stimulates and amplifies the next step in the clotting formation. If you stop the clotting cascade, you prevent the formation of clots. The end result of the clotting cascade is fibrin, which is the beginning of the clot formation. So blood coagulation system, there are three basic drugs that affect clot formation. Aspirin, which inhibits platelet aggregation or platelet clumping together. Warfarin inhibits the hepatic synthesis of vitamin K, which is needed to form clotting factors 2, 7, 9, and 10. Now remember, vitamin K is not potassium. Potassium is K plus, or potassium ion. Vitamin K is a vitamin that is required for the clot formation. It's produced in the liver. So a person who has liver failure or hepatic dysfunction, they will not have enough vitamin K. So they'll be at greater risk of bleeding, right? And then there's heparin, which inhibits antithrombin on factor 10A and on thrombin. So these are three different ways of preventing clots from getting larger. Let's talk about some of these. Aspirin. Now aspirin for clot protection is generally low-dose aspirin. 81 milligrams a day, sometimes as much as 325 milligrams. It's great for decreasing platelet aggregation. It does nothing to decrease pain or fever. Nothing. So the reason why we talk about that is when you are passing medications with one of us, one of the instructors, we're going to ask you, why are you giving this medication? And if you're giving 81 milligrams of aspirin and you say because they have a fever or because they have a headache, I'm going to say, no, that's wrong. Because 81 milligrams does nothing for a headache or a fever, but it does a lot to prevent blood clotting. So make sure you understand why you're giving the medications. Now, the other thing you need to remember is 81 milligrams or 162 milligrams or 325 milligrams. Every doctor has their own preference. They all work. They all work the same way. They all have the same duration. It's just some doctors prefer one or the other. Very commonly, if a person is having a heart attack, they'll be told to chew 4-baby aspirin. Why do we chew it? For faster absorption. Remember, absorption is dependent upon the route of administration. If you swallow a pill, it has to go into the stomach to be dissolved. But if you chew that baby aspirin and chew it, it's going to start absorbing into the tissues of the skin, and then as it goes into the stomach too. But it's already going to be in, so that's why we have you chew baby aspirin. So aspirin is a platelet inhibitor. It's used for heart attacks, strokes, and unstable angina. It inhibits the synthesis of thromboxane A2, which is a potent vasoconstrictor and an inducer of platelet aggregation. So it prevents vasoconstriction and clot formation. So that's a dual effect, very helpful. It works quickly. These are over-the-counter medications. Aspirin is over-the-counter, no prescription needed. You should never use aspirin if you're using another anticoagulant unless your doctor is specific. If your significant other or your father or grandmother is taking, let's say, warfarin, and they decide to take aspirin too because they figure if one is good, two is better, no, don't. Only if your doctor says to take aspirin with something else. You are at much greater risk of bleeding if you take those two medications. This medication, aspirin, irreversibly affects platelet function for the life of the platelet. 7 days. It irreversibly stops platelets from working for 7 days. So if you're going to surgery, do you think they're going to want you to take aspirin right up to the day of surgery? No, they'll have you stop 7 days, maybe even 10 days in advance. The dose of a single aspirin can last as long as a week. It's a very potent medication, and it's over the counter. There's platelet inhibitors. These are ADP receptor blockers. Remember, ADP is released when the damage to the cell happens, the vessel wall happens. Two most common are ticlodipine, or Ticlid is the brand name, or clopidogrel, or Plavix is the brand name. Clopidogrel is used more often, at least in this part of the state. Again, myocardial infarction, angina, TIAs, and CVAs, just like aspirin. And it alters the platelet membrane so that it can no longer stick together and form a clot. Different function or different cause from aspirin, but the same end result. So again, it's a different step of the clotting chain with the same end result, which means if a person can't tolerate aspirin for whatever reason, they can use this for the same end result. However, these drugs are very expensive, so that's why they're not used very often. Now, what if a person is having a stroke or a heart attack? Well, call 911 right away, immediately. You want to get them to the hospital fast. When they're in the hospital, they might be able to get clot busters. These are thrombolytics. Now remember, thrombo means clot, and a lytic or lysis is the breakdown. So a thrombolytic is a clot buster. These actually dissolve clots, like gone. It must be used within 3 hours of the onset of symptoms. Here's a key factor, though. If, let's say a person wakes up and they think they're having a stroke. Half their face is weak. They have a hard time talking, weakness. Those are stroke symptoms. If they wake up with stroke symptoms, when did it start? You don't know. So you will not be able to get thrombolytics. If halfway through the day, all of a sudden those symptoms happen, call 911. Hopefully you'll be able to tell the doctor the symptoms started 30 minutes ago, and maybe then you can use clot busters. Same thing with a heart attack. If you get to it quickly, maybe you can use clot busters. I say maybe because there are some specific reasons you use them or not use them. Thrombolytics are enzymes. The two most common of these enzymes are alteplase or activase. TPA is another brand name. Tenecteplase or TNCase is another brand name. There's streptokinase and urokinase. These are all clot busters. Remember, ACE, anything that ends ACE is an enzyme. And these enzymes dissolve, they promote fibrinolysis or clot destruction by converting plasminogen back to plasmin. So it degrades that fibrin, which causes the clots. It reestablishes blood flow and prevents or reduces or limits tissue damage. Now again, have to be taken quickly within 3 hours of onset. These dissolve fibrin clots. The goal is to reestablish blood flow quickly because with both heart attacks and strokes, time is damage. In the heart, time is muscle. In the brain, time is brain. The longer you're without oxygen, the more damage occurs and the more irretrievable the damage will be. When the thrombolytic therapy is completed, the person will be started on heparin and warfarin to prevent the reoccurrence of clots. Thrombolytics do nothing to prevent clots. They dissolve clots, but they do not prevent the formation of a clot. But I said there's reasons you can take it and can't. Now again, you take it for heart attacks and strokes, not angina, heart attacks and strokes, not TIAs, but only true strokes and myocardial infarctions. But there are times when you cannot take it. If the person has recently had surgery, if the person has recently had a traumatic injury, a car accident, if they fell during their heart attack and hit their head, unless it can be proven that they are not bleeding somewhere, they cannot have these thrombolytics. If the person recently, within the past week or two, actually I think it's 2 weeks, had a surgery, and you give them the thrombolytic, it will dissolve the clot in their heart or their brain and everywhere else in their body. So imagine what would happen if the person had, let's say, a bad hip injury, broken hip. They had surgery to fix it, and then they had a heart attack. You can't give them thrombolytic because it'll open up the heart, but it'll also open up all the clots in their femur and pelvis, and they will bleed out. that's bad. So these treat the clot, they don't prevent clots, and if a person doesn't get treated fast enough, or if they have a high risk of a other clot from surgery or accident, they cannot get thrombolytics. So what about the three amigos to prevent blood clots? The three amigos. These prevent ischemic strokes, myocardial infarctions, deep vein thrombosis, and pulmonary embolisms. These are very commonly used. You'll use these all the time in your career, whether you're in the hospital, a nursing home, home health, whatever. You will use these drugs all the time. Anticoagulants. Prevention is sometimes the best treatment. If you can prevent the clot from forming, you are way ahead of the game. So these are used to prevent clot formation from unstable angina, atrial fibrillation, mechanical heart valves, and major orthopedic surgery, hips and knees, things like that are going to prevent you from moving very well. These are very similar, but they all act very differently. Heparin, enoxaparin is the generic for Lovenox. Heparin is a generic. I don't believe there is a brand name for that anymore. And then warfarin or Coumadin is the brand name. And little hint or tip there: if you're dealing with a patient who is older, say in their 80s or so, and they're using warfarin, they may refer to it as rat poison. The reason for that is when Coumadin was first developed, it was developed to be a rat poison. It's no longer used as rat poisons, but many people still call it that. So comparing the three amigos, heparin, enoxaparin, and warfarin. Heparin is usually given IV. It can be given sub-Q. Not as much anymore as it used to. Now it's usually given IV. Enoxaparin is given sub-Q only, and warfarin is usually given orally. IV heparin, immediate action. Sorry. Enoxaparin, it's given sub-Q, so it's in the subcutaneous tissue, the fat. Onset 2 to 3 hours. And warfarin, very slow. 3 to 5 days before you get full effect from warfarin doses. Different labs are used to monitor these. Heparin, you use the APTT or PTT, partial thromboplastin time. Enoxaparin, there's no labs that can test for Lovenox or enoxaparin function. Warfarin, you follow the PT-INR. Their PT-INR are always done together, but the INR is the preferred method of measuring it. ProTime or PT, every lab will have a different value for ProTime being normal. But the INR is called the International Normalized Ratio. Every INR is the same regardless of the lab. So INR is what is used now. Convenience? Well, heparin must be given in the hospital. It's given IV. You will very rarely ever see heparin anywhere else. In fact, I don't believe it will be given anywhere else. Lovenox? It maybe is self-administered at home by the patient, but it's very commonly used in hospitals. Warfarin? It started with heparin or Lovenox until the warfarin becomes therapeutic, and then it's an oral pill that you can take wherever you are. Evaluation. What do you evaluate for with these medications? Well, all of them are very similar. You will always evaluate for hemoglobin and hematocrit, or the H&H. Heparin and Lovenox, you'll monitor the platelet count. These can cause thrombocytopenia, or low platelet count. So you would monitor the platelet count. Warfarin, you're going to monitor vitamin K intake. Where do you get vitamin K? Dark green leafy vegetables, spinach, kale, broccoli, things of that nature. It's not that your patient cannot eat spinach or kale or whatever they want, but they should try to eat the same amount all the time so that they have a very steady level of vitamin K in their system. If they normally eat none and suddenly they have a spinach salad, that will increase their vitamin K and make them more prone to form clots. Excuse me. There is a reversal agent for heparin and for Lovenox. It's protamine sulfate. That reverses heparin. Warfarin, the reversal agent, is vitamin K. And that's frequently given IM, intramuscular. So some of the side effects with all of these, you have an increased risk of the reading risk increases as you increase the doses. It has a positive relationship. As you increase the dose, you increase your risk of bleeding. Hematomas, or a hematoma is bigger than a clot. It's almost like a pool of blood under the skin. It's very painful, and it's actually risky. It can cause damage. Ecchymosis, bleeding gums, hematuria, blood in the urine. So you will obviously do a lot of patient teaching with these. You will tell your patients to watch out for all of this. They will bruise very easily. For Lovenox, that's given usually with sub-Q injections into the belly fat. And very commonly you'll see bruises about the size of a pencil eraser right around every injection site. You may not always see that, but that's a common site. But they will bruise really easily. May also cause nausea, vomiting, abdominal cramps, and then thrombocytopenia with the heparins, both the regular heparin and the low molecular weight heparin, or Lovenox. Contraindications. Why can't you take this? If they have a GI ulcer, if they're at risk for bleeding, are you going to give them something that will make them more likely to bleed? Probably not. Severe hypertension, very high blood pressure. You don't want them to be at risk of bleeding because of high blood pressure, you're at risk for an aneurysm. And if an aneurysm starts to leak and they have a reduced clotting ability, how bad will that be? Yeah, really bad. Recent surgery of the eye, spinal cord, or brain, or severe kidney or liver disease. And there will be increased therapeutic and toxic effects if they are currently using aspirin, NSAIDs, or alcohol, because all of those can affect the ability for a person to bleed more. So, you're not going to take aspirin with these. You may take NSAIDs, ibuprofen, and naproxen, Toradol, very carefully. And alcohol, you will probably not want to take alcohol on these medications. Heparin. This is the first drug that was used for the initiation of anticoagulant therapy, so it's been around a long time. This is monitored by lab tests. The partial thromboplastin timer, APTT. And they measure it according to control. Normally the partial thromboplastin time is 22 to about 34 seconds. And what they're looking for is 1.5 and 2 to 2.5 times that height for the effective range. You don't want too high because then you're in the toxic range, more side effects. You don't want under that because then you're not doing anything. It's given IV or parenterally only, IV or sub-Q. Again, mostly IV, sometimes sub-Q, and a lot of that is physician preference. It's also a cost thing. It's much less expensive than Lovenox, but more side effects. It has a short half-life, only 1 to 2 hours. And the antidote, well, it can be reversed with protamine sulfate. Now this indirectly interferes with the conversion of prothrombin, which is factor 2, to thrombin. The resulting deficiency of thrombin prevents the conversion of fibrinogen to fibrin and thereby inhibits clot formation. So it prevents the conversion of thrombin to thrombin. When you don't have enough thrombin, you can't convert fibrinogen to fibrin. See how that chain works? It acts immediately after IV injection and within 20 to 30 minutes of subcutaneous injection. So you give this IV, it's working right away. It's rapidly inactivated by stomach acid, so it cannot be given orally. It has no fibrinolytic activity. It does not eliminate current clots. It only prevents those clots from getting bigger. What does reduce clots that are already existing? Thrombolytics. So the low molecular weight heparins, or enoxaparin is the generic, or Lovenox is brand name. These are more predictable than heparin. It does not require lab monitoring. It's given subcutaneously only. These block coagulation factor 10A and thrombin, which prevents the completion of the coagulation cascade. So these work at the very end. Does not affect the pro-time or the PTT. Here's the advantage. Less potential for hemorrhage and a much longer duration of action. These can, when they were first being used, they were given twice a day. Now it's commonly once a day dosing. It can be used twice a day if the person is at higher risk, but mostly it's once a day. And again, these are given subcutaneously, most likely in the belly, the subcutaneous tissue of the belly or the belly fat. On some of your elderly people who are very thin, they don't have much tissue there, so you'll have to pinch that tissue up so that you don't actually go through it and into the deep dermis or even lower. And then warfarin. Warfarin, or the brand name is Coumadin or Jantoven. There's a couple of different brand names, but let's call it warfarin because that's the way it's almost always ordered. Warfarin is long-term prevention of thromboembolic disorders. So, DVTs and AFib-related strokes or mechanical heart valves. If a person had a pig valve replaced, by the way, you know that pig valves can be used in people's hearts too, right? If they have a pig valve, you won't need warfarin. If they have a mechanical valve, because it's metal or non-tissue, you will need to prevent clot formation. So then they'll be on warfarin for the rest of their life. Why would you use a mechanical valve instead of a pig valve? Pig valves last about 7 years, and then you need a new one. Mechanical valves will outlast you. With warfarin, prothrombin factor 2 is decreased by the oral anticoagulants. Now, this inhibits the activity of vitamin K, which is required for the activation of clotting factor 2, 7, 9, and 10. When you inhibit the blood clotting by interfering with this synthesis, now vitamin K is then reduced, and the depression of these clotting mechanisms is also reduced. So this affects inside the liver, which is why it's much slower than heparin, which is immediate, and enoxaparin, which is fast. Warfarin. Some important patient teaching, though. There are a lot of drug and food interactions that enhance the therapeutic and toxic effects of warfarin. Aspirin and Tylenol actually make warfarin more effective, as does cimetidine, which is an H2 inhibitor for GERD. Alcohol, sulfonamides, and foods that are high in vitamin K. And now, when you're working with me, I'm going to ask you, I like to ask people about patient teaching. And if you say I'm giving warfarin, I'm going to say, what are you going to teach your patient? Do not say you need to control foods high in vitamin K, because my response will be, and I'm telling you this right now, well, what aisle in the grocery store is vitamin K? Because it's not labeled that way. I want you to talk in patient language. So they need to avoid dark green leafy vegetables. Again, spinach, Brussels sprouts, broccoli, cabbage, parsley, even pistachios and dark lettuces. These have a lot of vitamin K. Can they eat those? Yes. But they have to try to eat the same amount all the time. So that's it for blood clotting. Again, this is a fairly complex lecture, but this is really important, and I hope you understood that there's a chain effect, and each of these medications attack a different part of the chain. Bring your questions to class, okay? And remind me, I have a story about what happens with a DVT when it becomes a PE, okay? I have a very concrete story on that. All right, come back for the last section, Section H. We're going to talk about cardiac dysrhythmias.